admission? Or you get the overnight, but you don't get
I think we can start, right?
already. So we'll make sure you have a good first impression. So she's sick, it's not like palliative situation. 12 centimeter aneurysm, that's legit. Yeah, that's legit. Nope.
Let's start.
Yeah. You guys ready to start? Allow me to sit down and then we can start.
Yeah.
Is that your spot?
Usually.
Usually? Is that the better view?
Yeah.
Unobstructed.
Because like if you're like over there, you're either like this or like this.
That's true, that's true.
It's either this or the couch.
Oh, the couch is nice.
Depends on if I've had lunch or not.
I should make sure that the online people
I think that's, I think Amar's on,
Sorry?
oh, okay, okay.
Oh, yeah. Yeah, really? Yeah, oh, she's very good.
Maybe we can text them, see
Very
if they can hear.
For the first week, I gotta get next week down. It's leaving today.
Good. Good morning, everyone. I am Mohammed Muftah, one of the third years. So today we're gonna talk about a very common case during inpatient rounding or inpatient service. The way I plan to do it is to be more kind of engaging. I need more participation from your side, kind of reverse classroom. So I will be kind of facilitator rather than like lecturer. Let's move forward. So we will pause at certain points. So we reflect on that part, give concepts. The big take-home message that I will give from the beginning and then will reiterate at the end is we in medicine think in a concept way rather than a list way. Say, for example, somebody asks you what are the causes of hypokalemia. So we used to think like a list in your brain. So you mention like 5 and then forget 5. So this is, I think, not the right way of learning medicine. This is good for exams, good for medical school, but when you transition to the practice, you need to learn medicine in context, which is the concept-based medicine. So I will try to illustrate these concepts as we move forward and go through the case. So to cut the story short, let's start by case scenario. So the slides is not gonna be fancy. So it's handwritten. So this is an 80-year-old female with history of AFib on aliquots. She has history of aortic stenosis and she has hypertension. This lady presented with history of fatigability and diarrhea for 12 days duration. Now we will pause and think. And what do you think and how would you approach this case? So I wouldn't limit you to the history. So we know that we will start with the history, analyze diarrhea, and then exam, and then labs. I would do them all together. And this is the way, that's the meaning of concept. So you do the diarrhea part, analyze, take the big point related to the case, and then at the same time expect what physical signs you want to know, and then expect what labs you want to see. It's not kind of these are the labs, no. You create, you synthesize the scenario, you synthesize the expectation, okay? So I want to hear now from you, what do you think about this lady, and what are the history, exam, and lab finding expected?
Could you characterize the diarrhea? Watery, bloody,
Excellent. Okay, so it was watery diarrhea. She had upper respiratory tract infection and she was having concern of CAP, which is community acquired pneumonia, 2 weeks ago, and she had a course of augmentin.
Did she have fever?
No fever.
How many times a day was it?
Excellent question. She said the maximum is like 12 times a day with a small amount. And it's being consistent like that this duration.
Any blood in the stool?
No blood in the stool.
Any recent travel?
No recent travel.
Associated nausea, vomiting?
She doesn't have any nausea or vomiting. She has just mild abdominal pain.
Was she in is like does she live in a nursing home? Is
She's coming from home.
Oh, home. Okay.
Yeah.
Does she have any other associated symptoms like sweating or cough or anything?
She denied any history of dyspnea, cough, no other symptoms.
Any myalgia or arthralgia?
There is kind of fatigue, but there is no arthralgia or myalgia.
Any sick contacts?
No sick contact. Excellent question.
Did it start suddenly or does she have a history?
It started over like days.
When was the last antibiotic dose?
That was like 3 days before the start of the diarrhea. So I just wanted to, for the sake of time, I want somebody to give me the concept. What's the concept? So we talked about the concept. When you encounter a diarrhea, what's your thought process in history? So kind of in history, like the concept is not like the frequency, bloody, not bloody. What do you want to know? What's the big goal?
Infectious versus non-infectious?
Excellent.
Acute versus chronic?
Very good. Yeah, so one thing is like infectious. Is this infectious or non-infectious? Excellent.
Acute versus chronic?
Excellent. So is it an acute or chronic? Okay, so for the sake of time, my approach to diarrhea and the way that I usually approach a diarrhea is the thinking of localization. I think about, is it small intestinal diarrhea or colonic diarrhea? And I think I use that a lot, and I think this is a very good way to approach it. So by starting by these questions, if the diarrhea is high frequency, small amount, associated with tenesmus, right? You know, tenesmus, if there is proctitis and inflammation of rectum, that makes the patient feels always incomplete evacuation of bowel, and this is one of the causes why the frequency is high. And if there is blood, we call it dysentery, right? But if no blood, it's gonna be colonic diarrhea kind of things. And then small intestinal, which is very large volume because it's malabsorption most likely, which usually have less frequency, maybe once or twice, and it's usually fatty, and a patient usually reports seeing these kind of stuff like the color of stool is pale, and it's usually very offensive. This is not a big point, but again, these are the big things. Once I classify colonic for this lady, for example, I would ask myself, colonic diarrhea, is it acute or chronic, or is it infectious or non-infectious? And from there, you will start. So say, for example, this is acute colonic diarrhea, most likely, 12 days, acute colonic diarrhea. So what are the causes of acute colonic diarrhea? Non-bloody, because if there is a blood, you think about certain organisms, certain condition like ulcerative colitis, like E. coli, enterobacteria, but this is non-bloody. So thinking about, Shigella and amoebiasis, whatever, it's unlikely in this case as far as it's non-bloody. So it's non-bloody colonic diarrhea with, like Dr. Shah said, the patient has history of augmentin use. So this is most likely. So the big thing, right? So the antibiotic usually give you one of two. It's either antibiotic associated diarrhea, which is not to the point that they have pseudomembranous, or there may be pseudomembranous colitis, like we should think in this case, okay? So this is most likely antibiotic-associated diarrhea. This is the big thing. So the big concept about the diarrhea is, number one, the cause. Second is the complications, right? What do you think the complication of diarrhea of this severity on your patient, and what do you expect to find?
Dehydration.
Excellent.
Electrolyte abnormality.
Excellent. So, can you be more specific? What electrolyte abnormality would you expect?
I would expect potassium losses.
Excellent.
Magnesium as well.
Excellent. So hypokalemia, this is the big thing, right? And you can relate to the fatigue, like it's hypokalemia, right? Because people with diarrhea, usually they have hypokalemia, and this will account for the fatigability as well. So dehydration, hypokalemia, any other electrolyte abnormality you would expect in the BMP, the metabolic profile. Metabolic? Excellent. So diarrheal fluid contains very large amount of bicarb. And that's why, because the pancreas is secreting the bicarb. So this will be bicarb loss. My big point, I think this is a big concept in medicine. The classic and the 95% of people in medicine who have hyperkalemia, usually they have acidosis. There is a long pathophysiology behind this. Hyperkalemia linked to acidosis, hypokalemia linked to alkalosis. And there is a big pathophysiology, and it's the kidney and the renal handling of the situation that give us this pattern. So when I see hypokalemia, and you don't give me any context, I would say this patient alkalotic. This is the big thing in medicine. And if I see hyperkalemia, I would say this patient most likely acidotic. Maybe because of cell shift, but it's also because of the kidney and the renal handling of the situation. But there is exception of this 95% rule. Sometimes you have hypokalemia and you will have acidosis, which is not common. If you have hypokalemia and acidosis, diarrhea, one of the uncommon causes of hypokalemia and acidosis, and again another uncommon, which is renal tubular acidosis. So these are the big things. So it's kind of uncommon to find hypo and acidosis. Anyway, so the electrolyte abnormalities. So this is one complication. Dehydration, signs of dehydration. What are the signs of dehydration, and what do you think dehydration? What are the signs that you wanna see on your patient?
No urine output.
Excellent. Yeah, she has that. Yes, she has dry mucous membrane and skin turgor. Blood pressure, right? This is the big thing. And she has AFib, right? These are all things that I want to relate in this slide, so we move forward, everybody on the same page. So first, hypotension. Now, this most likely hypovolemic shock, right? This beyond just simple dehydration. Patient, old age, doesn't have a good reserve. She has like pouring, diarrhea, and she has hypotension. And tachycardia, right? These are the big thing. Tachycardia in the context of AFib will give you like AFib with rapid ventricular response, right? And again, I will come to this point. And how would you respond to this situation? Do you target rate control, or you treat the dehydration first? You know, this is very important. And the third, which we usually see, is the CBC. Sorry, I jumped from the physical science to think, because it's a concept thing, okay? So electrolytes, what do you expect in the CBC, complete blood count in this lady?
Hemoconcentration.
Hemoconcentration, okay. So if I ask you one thing you want to know about the CBC in this context.
Leukocytosis.
Excellent. So leukocytosis, and especially neutrophilic leukocytosis, because if you are thinking about pseudomembranous colitis, leukocytosis is one of the signs of severity, right? If we are thinking about it, because like WBC is more than 15, so it's gonna be classified as moderate or severe and things. Okay, And now back to the physical signs. What's the most important physical sign other than the blood pressure and the pulse and signs of dehydration in this lady?
Abdominal examination.
Excellent. Excellent. So why you're interested in abdominal examination?
Well, the pseudomembranes will find abdomen could be distended, so that you have generalized abdominal tenderness.
Excellent.
If there is tenderness, also want to localize it.
Yeah. So colitis in general and pseudomembranous colitis is non-different, can give you toxic megacolon, right? What are the complications, right? If it's severe colitis, it's gonna give you colonic dilatation and toxic megacolon. At this point, this is surgical, not medical emergency. Maybe there may be abscess, there may be perforations, So abdominal examination is very important, and CT scan abdomen is very important in this context because we want to know more about this. So I'm not saying that I'm jumping, but this is the context. This is the big way I think about it. So this is lady with diarrhea. They give us the sign out from the ED, and lady with diarrhea and 80-year-old like this, okay? And then I go through EPIC. First, I go to the story, and then go to the physical sign. Oh, she is shocked. She has tachycardia. And then I go to the labs, and I say, bicarb is low, potassium is low. So this is the way we think about it. And then leukocytosis. Is there any CAT scan? So EPIC, there's a lot to look for. But if you know what to look for, you will go for your things and collect. And you synthesize the scenario. So if anybody asks you, what's going on? You are going to call the surgeon or the GI, you will synthesize it because you know it. A patient who is 80-year-old presented with 12 days of diarrhea. The patient abdominal exam, say for example the surgery is concerning, there is a tenderness around the abdomen, and CT scan showed colonic dilatation, like patient has leukocytosis. So you can convince other people during the communication to come and see your patient and give you a help. Anyway, so history, examination, and labs. So we expected what we're gonna. One last thing before I move from this slide. What does aortic stenosis in the stem, in the background, tells you? Because we know this patient has most likely hypovolemic versus septic shock, right? We don't know. Could be cardiogenic. There is aortic stenosis. We don't know the background. She has AFib. We don't know. But I want you to, because this is a very common cases we encounter in an inpatient setting, aortic stenosis. And what do you think? What does that mean to you? What does that add to the management? Patient with this context, and she has history of aortic stenosis. What you want to know more, and what are the things that you want to change in your management?
Severity of the stenosis.
Excellent. What does that mean? Very good. Yes, severity of aortic stenosis. We label people with aortic stenosis, but the aortic stenosis that we usually concerned about is the hemodynamically significant aortic stenosis that we call severe or critical aortic stenosis. And the number which is I usually recall is like 1440. So if the echo finding aortic valve area less than 1, or velocity more than 4, or gradient more than 40. These criteria, one of these criteria will mean the patient has significant and hemodynamically significant aortic stenosis. There are exceptions and there are other things, but big picture is like, this is the thing. This is what I want to know. So I want to review the echo in the system. So it's diarrhea, it's pseudomembranous colitis most likely, or whatever it is. But I want to give fluid. And giving fluid to a patient with the critical aortic stenosis is, you have to be cautious. Because the classic teaching is, Patient with aortic stenosis has significant like pathophysiology, and the preload has this narrow margin. What does that mean? The hypovolemia is going to affect them to the point that they get shocked very easily, and the fluid resuscitation give them overload and pulmonary edema very easily. And that's why we are always, I don't remember Lasix dose of 20 except in patient with aortic stenosis. I might consider this. Otherwise, cardiologists usually don't do that. But the thing is, if you want to give fluid for septic patient and he has a critical aortic stenosis, you have to be careful. This is that take home. Now, this is another goal for this lady. We need to know what's the severity of this aortic stenosis. Do we ignore it during our resuscitation, or we need to pay attention to it? At this point, I will have low threshold to call people from CCU, cardiology, whatever, to help, okay? All right. So I will give you the physical signs for this patient. So this patient, big thing, so we know that the scenario. So the blood pressure was initially 90/60, and the pulse rate was 120, irregular, and the patient abdomen was soft, non-tender, and lax. So these are the physical signs. And then I would go and give you more information now. So this slide, these are the questions that we asked, right? What do you think? Can anybody, can you read these numbers and think loudly? What do you think about these numbers? Like explain, justify, any steps you want to take based on these numbers?
So potassium is 3.9.
2.9, yeah.
Which is pretty low, which is likely because of the loss in the diarrhea fluids. So whenever any resuscitation measures we want to take, this is something we would keep in mind. Same with sodium, which is 129. Potassium is 15, which is high. So patient is hypercalcemic.
It's not calcium, so the, CO2 usually it's the HCO3, yeah.
It's 15, so the gap. Patient is likely acidotic because the bicarb is low.
Yeah.
Then creatinine is 1.5. Patient's blood urea nitrogen is 30. Calcium is 8, so patient is hypocalcemic, but the albumin is 2.5, so we would want to know the corrected calcium.
Excellent.
Phosphorus is 1.9, which is low, and the magnesium is 1.5. So just going by the electrolytes, patient has a lot of electrolyte losses, and if any for all the resuscitative measures for the fluids, we would be wanting to replete them.
Yes, excellent. So, yeah, so the hypokalemia, explainable. She is on hydrochlorothiazide, by the way. So this is another thing. Hyponatremia, this hyponatremic dehydration, right? Bicarb low, anion gap, I forgot to mention, was normal. So this is the typical for diarrhea. And creatinine, most likely pre-renal in this context. I forget the baseline. Calcium, like you said, corrected. Phosphorus 1.9 is slightly on the lower side, and this lady at risk of refeeding syndrome. If you give her like this, so we cycle it almost daily in the first 3 days at least. And then the CBC. What do you think about white count of 15 and 14 of neutrophilia? This is related to our thought process. And hemoglobin 8.5, platelet normal. And then C. diff was sent. This is one of the things that it's pending. And also lactic acid came back 6, which is high lactic acid. And in this context, dehydration, sepsis is going to be high. Blood culture sent, and it's pending. UA, which is, the urine examination was clean. Chest X-ray was normal. ECG, next slide, I'm going to give you, it's not the patient ECG, but it's one of the ECGs that looks like it. CT, abdominal pelvis, no acute intra-abdominal findings. So this is no surgical indication as we discussed. TTE 3 months ago. There was mild to moderate aortic stenosis, which is not the critical aortic stenosis. So we are okay with giving fluid resuscitation for this lady. and the ejection fraction was 65, so we can give fluid. And then PUCAS, like a quick PUCAS, hyperdynamic left ventricle. Like the left ventricle is hyperdynamic. That means the patient is hypovolemic, and also the IVC, was collapsed. So these are the kind of to test for fluid responsiveness, and this is another topic we can talk about it later. So overall, at this point, the patient has most likely diarrhea, most likely infectious, most likely because of C. diff. She has a lot of electrolyte disturbance. Is this patient shocked? Question. Do you label this patient as shock or no?
She's on the borderline blood pressure wise. So just from a vital sign standpoint, I would say yes. Soft blood pressure.
Okay.
In the setting of someone with even mild to moderate AS, I would say she's in hypovolemic shock.
So what is shock?
Yeah.
Also the lactic acid.
Yeah. Good point. Yeah.
You're looking for signs of end-organ damage, which
Yeah.
you have with those, with the creatinine, and then you have the lactic acid, which is a sign of global perfusion damage.
Exactly. Yeah. So shock is hypotension plus hypoperfusion. Some people might not have that number, but they have hypoperfusion, right? So hypoperfusion, common organs, kidney, there is an AKI, lactic acid, tissue perfusion, and capillary refill time, which is a very good indicator. So, and mentation, if the patient altered mental status, this is shock. So if the blood pressure like 85/60 and the patient has no lactic acidosis, I would say this is hypotension. Especially in some people, usually they live with this. But if there is that number with the signs of hypoperfusion, so you need to have some signs of hypoperfusion because this is the shock. Shock is hypoperfusion. And now this lady has shock, okay? We'll classify the shock, but this is shock in the context of diarrhea, most likely infectious diarrhea. So these are the big points. Before I move to we do it, I think loudly. If somebody, if I take sign out from the ED about this patient, I think loudly. I think all of the seniors agree with me, like we do it this way. And that's why I want to deliver this message through this presentation, that it's not just reading the symptom, it's the context. Learn by doing and learn by learning these contexts, and these are very common cases. By doing them more, you will learn more. So this is not the real one, but this is, it's more or less the same. What do you think about the ECG? Again, what I would recommend, the ECG, there is levels. I would say in the first 3 months, I would aim for level 1. What's the meaning of level 1? Level 1 is picking big things, without looking deeper into the detail. ACS, AFib, VT, the big things. No details. Like the aim of the level 1 is not to miss the big arrhythmias. That's the thing. So like this one, the patient, known case of AFib, right? So anybody can read this. I know the time is not allowing us to to explain everything, but what do you think about this? Irregular QRS complexes and yes, excellent. So it's all about P wave, right? So the thing is P waves. So the P waves, the baseline, sometimes one might argue these are P waves, but they are very disorganized. They are not so toothed. They are not like multiple morphologies to call it like MAT, MAT, multifocal. It's not, but this is a regular baseline. I would say this is bizarre. And it's eerily, like we call it like coarse AFib, and then with time it will be less like F waves and then flatline. Anyway, so being in AFib itself is not an emergency. The emergency lies on the rapidity of the rate, like the fast rate. And we can accept as high as 110 to classify it rapid ventricular response or slow. And sometimes in this context that we know there is reversible cause we are working on, we might hold off on treating this AFib. And this ejection fraction is good. So we know the patient is not very dependent on atrial kick. This is another discussion. But for this context, I would give fluid until I achieve the euvolemia. Once the euvolemia achieved, I will look at the rate and then we'll go from there. Okay, I will let you know what happened to this lady. Now I come to the problem list. This is the way we do it. Like, now I told you about everything about this patient, try to explain the concept, try to push these things. What do you think? Now you are admitting this patient and you want to create the problem list. And it's in order of priority and importance. What do you think the problem number one that we should write in this patient? Excellent. So shock, there is organ failure. So organ failure is acute hypoxemic respiratory failure, shock, AKI, these big things. So shock. And you know why we classify this patient as having shock. And then, what kind of shock? So this could be hypovolemic, okay. What else? Septic. And what else? Cardiogenic. So the echo showed hyperdynamic, right? And the AS wasn't like significant. Do you think maybe there is pericardial effusion, right? So that may be one of the reasons you might think about cardiogenic. Excellent. So could it be like PE, right? Yes, yeah. Could it be PE? So I know there's a big two reasons, right? Big two etiologies. But in the back of your mind, if this shock doesn't respond to your management, what's the backup, right? This is the way we think. So we'll try the sepsis, treat the sepsis, the hypovolemia, and then I would think if no response, this lady might have PE. So the right ventricle is not dilated in echo, whatever, you have to justify these kind of things. Anyway, so I would go for sepsis. So you want to treat sepsis, right? So we don't have a lot of time, and that's why I'm going to cut the things short. So how would you treat sepsis? This is very common, okay? Sepsis and septic shock. How would you treat sepsis?
Broad-spectrum antibiotics in the first hour of presentation.
Okay. Mm-hmm.
Fluid resuscitation.
Fluid resuscitation, excellent. How much fluid?
30 cc.
Okay. And the 30 cc, this we'll discuss, as we move on our morning reports. But the 30 cc was downgraded from like recommended to suggested. So it's not like very recommended. The evidence is not very strong about it. But fluid, okay? Okay, so again, we don't have time. I don't want to spend a lot, but I will make it very simple. The way I think about sepsis, I want everybody to think sepsis 6 plus source control. I know I'm not explaining everything, but this is the most important thing in sepsis. This is a European thing. This is a UK guideline. So in the NHS, the system in the UK, the first thing they teach the newcomers to the practice about sepsis is sepsis 6. So what's sepsis 6? This is what we do, but it's in the context of this. So number one, we give oxygen. So this lady, you will have, muscle memory or something that you want to do on your patient. So if the oxygen saturation is than 94, we'll aim for it, okay? Take blood cultures. So these has to be in orders. So take blood culture sent, and for this lady was sent, okay, blood culture, because we want to know what the organism is. And then give IV antibiotic. So what are the antibiotics? And this is something that you will learn. If you don't have a clear source, like HIT everything, right? So you aim for everything. Broad spectrum antibiotics. The classic in our hospital, we give cefepime to cover for gram-negative and vancomycin to cover for the MRSA, which is very, aggressive bacteria. So these are the big things. And then we'll wait for clinical signs, we'll wait for a culture result, and then we call it de-escalation to the antibiotics to that organ. If we have source. So in this case, most likely we have source, right? Do you think we have source? It's diarrhea, right? And we think it's pseudomembranous colitis. What do you think the antibiotic option? And do you think cefepime, which is cephalosporin, is going to be good option in this lady? Because this is the thing that we use, right? Everybody will use them. And unfortunately, she was given 1 dose of cefepime.
Make it worse.
Yeah, so the pseudomembranous colitis, there are antibiotic, they classified like first tier and second tier, that's very likely to lead to membranous colitis. Augmentin that she had is one of the first tier, and cephalosporin. So these are one of the biggest things. So cefepime might not be the good antibiotic. And how we treat pseudomembranous colitis, especially with this leukocytosis, with this concern. Oral vanc, excellent, and she had it, and IV flagyl, right? So she had the IV flagyl and she had the oral vancomycin, because we think this is most likely pseudomembranous colitis, right? Okay, so this is just a big, and then a fluid challenge. So then the fluid, there are a lot of studies about the fluid, a lot of controversy. What type of fluid? But the practice is give fluid as far as you feel the patient needs it. So that's why I mentioned PUCAS, hyperdynamic, and I mentioned collapse IVC. This is the PUCAS. You will learn it. It's easy and important in the ICU especially, and the patient dehydrated, so we want to give. At least you will give like 1 liter, 2 liters, 3 liters, 4 liters, as far as you know this patient is going to need the resuscitation. And all the studies, there are 2 studies. One of them actually came this year, February, this year, like 3-4 months ago. It's called Clover study, and failed to find any difference between conservative and liberal fluid management. So there is no difference. They failed to find any difference in mortality, 90 days mortality. So I mean, fluid, it's up to you. That's the thing. It's up to you. And then I want to pause here, because the fluid for this lady, looking to the heart rate, looking for the lactic acid, looking for the, if the patient respond, when you feel like the fluid, you give enough blood, that's fine. If the patient does not respond, here where you call the ICU or the PCU, whatever the patient, and start the pressors. And the first line pressor, like please record it, is norepinephrine. It's the Levophed. Start with it, and if the patient needed the second, this is going to be profound shock. So we'll call it profound septic shock if there is vasopressin. So this is the second line, and after that you can start the steroid. These are the guidelines when you use the steroid in septic shock.
Can you start norepinephrine afterwards, or do you have to go to ICU?
So you can. So there are 2 big things. You can start it in peripheral line, which is important according to the guidelines. At least as far as you know that this is going to shorten the resuscitation, and patient might go out of shock within short time. And PCU, our PCU, usually the protocol, they accept 1 pressor. Once the patient maxed on 1 pressor, so they cannot give 2 pressor. That means the patient has to go to the ICU. Okay. So the other thing. Serum lactate. Sorry, I was like jumping. So serum lactate. There is a very strong evidence. That says lactic acid guided resuscitation improves mortality. And there is one study called the Andromeda shock study that compared the capillary refill and lactic acid. They find a little difference, but lactic acid still be used. And there's a caveat to that. This is another story. Last thing, especially urine output is very important because you want to give, INOs. So you have to make sure that you have the INOs. So this is sepsis 6. Every item tells you a story, which is very important. And finally, don't forget source control. In our case, the source control, most likely it's pseudomembranous colitis, the patient on precautions, we are giving antibiotic. We think we are doing source control. CT scan, there is no abscess, there is nothing surgical. So I know if there is no source control, don't expect your patient to improve. That's a big thing. So we usually have like patient with ascending cholangitis and they have the gallbladder stone inside. No matter what antibiotic you give, no matter sepsis 6 you do, it is all about ERCP and taking the stone out. So source control is very, very important, okay? Sorry, I was so fast in the last slide, which is important. So the take-home messages. So this is my personal advice to the newcomers. Learn concepts. I try to engage that in my explanation today. So learn by concept. It's not by raw information. Learn by doing. So don't expect that you will know everything from the beginning, even if you are a high-tier student. So you will learn by doing, and you will make mistakes. So by doing. So if you read, you memorize. But if you do, usually you know. So this is if you do, you know. So do things. And then my big advice is in the first 3 months, which is now, 75% of your focus should be on the system and try to develop a habit. And you know what I mean by a habit. Waking up at 5:30, coming, doing things, sign out, system, how I log in, how I do things, develop a habit. This is very important. And then 25% medicine, like knowledge, take the back seat. And then as you transition the second and third trimester, which is 3 months, you usually transition, you reduce that 75 and increase that 25 until the end, the last 3 months, you will learn like 75%, maybe 85% medicine and leadership. You take more leadership, try to take the role of second year because you're gonna be senior. And less than 25 system. System is always, we learn the system as we move forward. Last thing, the more I know, the more I realize how ignorant I am. This is one of the Arabic saying, and I think this is totally true. Any questions? I came to end of this. Sorry, I went beyond the time, but